Okay. Okay, I will, now it's recording. So, mm, okay. Can you see now the canvas that I am in?
Yes. Yeah.
Thank you. So, um, okay. So, yeah, basically I mean, this is the welcome to the course that it was uh, like already there when I got the course. Which if you go to the different tabs, you will see some information that actually is not like here we have the base resource and the consultation resources that we are using, but also we're going to implement another book that you're supposed to have access to. This is the Candle, the Principles of Neuroscience, but it is not here. So I'm gonna change also this later on. But basically, what I wanted to show you is that if you go here to the where is it? Oh, sorry. If you go to the where it is general information, I think. And in no, sorry, it was not this one. This is nothing important. Here, course description. Thank you for sharing your screen to turn on your camera. That helps me a lot. So all of this that is here, forget about it. It doesn't work. It's not what we're supposed to have. And then we're not gonna see. I mean, we're gonna see some of these things here, but what we're gonna see here is now you have access to syllabus. I gave you access yesterday. And here, so here we have all the course description that we should check. So we have 5 weeks. We have also here the national exam that is this day. I don't know if you already knew. Okay, so book that day, that hour. That's gonna be the national exam. Okay, and then we have for each week we have some of the things. We are a bit behind of schedule because the first class basically we couldn't use it for anything, but we're gonna advance, and then we also need to how many are we now? 11. We need to decide when can we have the class for to recover the one that we missed on Thursday. That actually was very good because I was almost dying of a cold that day. But yeah, if we have that, I think we are gonna be okay. So let me see if I can show you this part. Do you see now the PowerPoint? Let's see. Yes.
Yes.
Yeah. Do you see the big screen?
Mm-hmm.
Perfect.
Yeah.
Perfect. Nice. So here we go again. Hello, my name is this one, and we are gonna start with the lesson. And we need to decide some of the things. That's what I was explaining. The course is actually what I show you. You have all the information there, and basically what you guys need to do is actually try to read a bit before the lessons for you to have a bit of understanding. And here we have the evaluation of the course that we have now. It's not 70%. I got to know that you got a bit scared that it was 70% last time, but it's 40% of the is for the national exam. Then we have integrative case with AI that you have to deliver in the last week, and then we have 30% class activities. And for the class activities, I want to have 10% of participation from your side. So what I was thinking to do, and for trying to make this a bit more dynamic, I am going to write your names every time that you do when you do when you participate, but it's not any participation. It's not good morning, which is also very good when you come and you enter and you say good morning. And then you have to give something of content, something that is actually something of the homework, something or the things that we are discussing. And that I'm going to write your name, and then you need to do only once per class, and that's going to be your participation. So every time that I ask something and then someone participate and ask the name, and then we put them down, and then I will count that as a participation for the day. So we have 10 classes. I'm going to write 10, so it's going to be 10 points, something like this. And then we will have the projects and activities that we're going to give. It's going to be maybe 5 or something like this. And then the quizzes that I'm going to double check them, all of them in Canvas for you to do them. And just to check that it's actually the related to the course and not also the ones that we were checking before. Okay, questions? Who is against? Who's agree? Everyone? Yes?
Yeah.
No? Cool. Perfect. Okay. Perfect. Cool. Now we're gonna start with the beginning, and this is what I asked you to read in the email. What I wanted you to basically that we start from here, and this actually I liked more this topic than the ones that we were having before, because this is more we can have an application of it from your side as well. Who have had a headache before? Yeah, everyone, almost. Yeah, no. After night partying, and then well, I don't know. I at my age now, I get hangovers. Before I wasn't, but I don't know you guys if you have a headache after a night of going out, etc. So, but most importantly here, who has migraines? Migraines, sorry. Nobody suffer from migraines? Cool. That's okay. So we're not gonna have anybody that actually could tell us a bit about the migraines, how they feel, and everything. Actually I developed migraines when I arrived here so I arrived living to Stockholm 8 years ago, and then before that I was not drinking any coffee. I never liked coffee. But Sweden has a very strong culture of coffee. They drink a lot of coffee. I think it's the country with the most consumption of coffee per capita in the world. And then I basically also when I came, the jet lag hit me very hard. So I was drinking a lot of coffee, and then after I don't know maybe 1 week drinking a lot of coffee before like after not even drinking it before, I developed what it was an aura and what it was a migraine. So I only had it once. I stopped drinking coffee and that disappeared. I never have had another after that, but I kind of like I can relate with the symptoms and to know actually how it feels. So yeah, let's start from the beginning. Who wants to participate? Who wants to tell me something about the pathophysiology of headaches? Anybody?
I can say something. Well, from what I know, headaches come from the um meninges.
Okay.
Sorry, I don't know if that's like a fact because I remember that we saw something about headaches in the other class, and they were talking about that the main thing about headaches is that they are, I don't know how to say meninges in English. Sorry.
Meninges, meninges is like this.
Meninges. Yeah, it's the same. So yeah, that's what I know mainly, and that they, if you're dehydrated, you get a like a really bad headache. I I I get to get that a lot because I don't drink enough water.
Okay. Okay, that's good. That's interesting. That gives us a lot of food for thought. Who else wants to say something? What do you think? Why because of the meninges? Why not because of something else?
Because it is connected to the trigeminal nerve.
Okay, okay, that's something good. What is the trigeminal nerve?
It is the one that is and it transmits nociceptive signals that
Okay,
it to direct to the brainstem.
okay. A lot of information there that you need to actually understand very well. That what's basically the whole thing from 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 the course. And actually, I'm gonna stop a bit this, and I'm gonna show you like it this week. What we're gonna check is the pathophysiology of headaches. So we need to understand what is the pathophysiology of generation and perception of pain, which is not the same. Then explain, and this for this, I mean, what we're gonna basically see today, maybe, and we can maybe, yeah, advance. So, but it's explain the neurogenic theory of cortical depression that explains migraine, and understand the vascular theory. In this vascular trigeminal with extravasation of neurogenic substances, and then how to manage actually these headaches. So this is basically what we need to get from this first week with the first topic. So that's why I was telling that is actually important. What else? What else can you tell me about the pathophysiology of headaches? Someone
I
else?
think it's good because not all parts of the brain are pain sensitive. I think only dry matter and blood vessels have nociceptors, but there are other areas that are pain insensitive, which is why sometimes brain surgery can be performed while awake.
Okay, that's very good, and that's something very important that we don't have nociceptors in all of the parts of the brain. So, or in the whole body actually, there's some parts that they don't have this nociceptor. So, I have a lot of questions. Like, for example, what if I ask you how many senses do we have? ¿Cuántos sentidos tenemos? Who wants to answer that?
Like the receptors or senses as in like
Yes.
olfactory.
Yeah, exactly like that.
Ah, five.
5. Okay. Who gives more? 5, 6, 7, 3, 4. What do you think? So what is the concept of a sense? Like, why do we have this yeah, basically, how do you smell? How do you touch? What is the basis of that?
It's maybe related to like the afferent nerves or like this sensory afferents, I mean, which is how we perceive the environment and
Okay.
how we get that information to our brain.
Okay, perfect. So Pamela, that's good. So that you have receptors, you have nerves, you have communication to the brain. So you are telling me that we have only 5 receptors.
And no,
Okay. So how many receptors do we have?
too many to count, probably.
No, not too many to count. We have many different receptors, and we actually know all of those. But I want some examples. So let's go for examples. What do we feel?
Maybe temperature or like
Okay,
different
temperature,
textures.
textures. Okay, so one is the temperature. We have sensors for temperature. When are these sensors working? When it's too cold or when it's too hot, or so we have some sensors in our body that actually are thermoregulated, and then they will actually tell that. And then we have other that is the touch, right? So that's, for example, the textures. What else?
There's
Also, like,
one. Go ahead, Pame.
no,
Sorry?
There's two different kind of pressure receptors. One that are more like for hard pressures, right? And one that is for like lesser pressures, one that detects vibrations.
Okay, so we have the osmoreceptors, right? So we have these that will tell us how is the actual tension of mainly let's talk about blood. So we have mechanoreceptors there that actually will tell us how is the pressure and the tension in our blood vessels. What else?
We also have like the chemical detection receptors, like capsaicin from spicy food.
Okay, that's a mechanoreceptor too. That's also and it's the whole other kind of receptors actually that we as Mexicans we have very well trained. Pamela, what do you wanted to say?
well, I was gonna say like the ones for pain, which relates to this, I think. Then I think nociceptors.
The nociceptors. Perfect. So if we count all of these 5, and then we already have one out, that is actually the for the touch that they were saying. All of the other 4 are not the taste. It's not the sound. It's not the olfaction. So there are way more receptors that are going to help, and one of those is the nociceptors that they are really important for us today. So if we actually, I think we have, yeah. So the next question that I have is what is pain?
Well, I would say that it's an answer, a reaction to a stimuli like heat or pressure. And it's like a physiological answer to know how to react if we're in danger, maybe.
Okay. It is actually those are different receptors. So one are the receptors for heat, and for pressure, and the other is the receptors from pain. So I want you to have you, like, I think almost everyone has been burned by touching something that it was too warm, right? If you think about it, or we can do the experiment now, we can just put something to boil and then we just put the hand on there. What do you feel first? The heat or the pain?
The heat.
The heat, okay? So there is different on these receptors that actually are the ones telling this part, and pain has different, like it has a part of all the physiology part of that. It's also, there is something that is the psychological part of that is actually super interesting. I'm gonna show you a video, but first of all, do you know who was the Nobel Prize in 2021? No? Okay. Homework. Nobel Prize of 2021. Like half a page of who were the ones that did the network got awarded with the Nobel Prize and why, for sure.
I have a question about that.
Yeah.
Is it only about medicine or
Yes,
every?
yes. Only about medicine. Sorry. It's yeah, it was medicine. Yes. The problem is that sometimes the chemist Nobel Prize is also related to medicine, but in this case it's just medicine. Okay, so I'm going to show you a video, and I don't know how this will work, but let's see. Okay.
We can't hear it. I don't know if we're meant to listen.
Yeah, the audio is so.
You cannot hear?
No.
No.
Maybe you have to share with audio or something.
I'm going to maybe just do it here. Wait. Okay. Okay, let's see if it works now. Okay, here we go again. Now?
In 1995, the British Medical Journal published an astonishing report about
Can you hear now?
Yes.
Perfect.
a 29-year-old builder. He accidentally jumped onto a 15-centimeter nail, which pierced straight through his steel-toed boot. He was in such agonizing pain that even the smallest movement was unbearable. But when the doctors took off his boot, they faced a surprising sight. The nail had never touched his foot at all. For hundreds of years, scientists thought that pain was a direct response to damage. By that logic, the more severe an injury is, the more pain it should cause. But as we've learned more about the science of pain, we've discovered that pain and tissue damage don't always go hand in hand, even when the body's threat signaling mechanisms are fully functioning. We're capable of experiencing severe pain out of proportion to an actual injury, and even pain without any injury, like the builder. or the well-documented cases of male partners of pregnant women experiencing pain during the pregnancy or labor. What's going on here? There are actually two phenomena at play: the experience of pain and a biological process called nociception. Nociception is part of the nervous system's protective response to harmful or potentially harmful stimuli. Sensors in specialized nerve endings detect mechanical, thermal, and chemical threats. If enough sensors are activated, electrical signals shoot up the nerve to the spine and onto the brain. The brain weighs the importance of these signals and produces pain if it decides the body needs protection. Typically, pain helps the body avoid further injury or damage, but there are a whole set of factors besides nociception that can influence the experience of pain and make pain less useful. First, there are biological factors that amplify nociceptive signals to the brain. If nerve fibers are activated repeatedly, the brain may decide they need to be more sensitive to adequately protect the body from threats. More stress sensors can be added to nerve fibers until they become so sensitive that even light touches to the skin spark intense electrical signals. In other cases, nerves adapt to send signals more efficiently, amplifying the message. These forms of amplification are most common in people experiencing chronic pain, which is defined as pain lasting more than 3 months. When the nervous system is nudged into an ongoing state of high alert, pain can outlast physical injury. This creates a vicious cycle in which the longer pain persists, the more difficult it becomes to reverse. Psychological factors clearly play a role in pain too, potentially by influencing nociception and by influencing the brain directly. A person's emotional state, memories, beliefs about pain, and expectations about treatment can all influence how much pain they experience. In one study, children who reported believing that they had no control over pain actually experienced more intense pain than those who believed they had some control. Features of the environment matter too. In one experiment, volunteers with a cold rod placed on the back of their hand reported feeling more pain when they were shown a red light than a blue one, even though the rod was the same temperature each time. Finally, social factors like the availability of family support can affect perception of pain. All of this means that a multi-pronged approach to pain treatment that includes pain specialists, physical therapists, clinical psychologists, nurses, and other healthcare professionals is often most effective. We're only beginning to uncover the mechanisms behind the experience of pain, but there are some promising areas of research. Until recently, we thought the glial cells surrounding neurons were just support structures, but now we know they have a huge role in influencing nociception. Studies have shown that disabling certain brain circuits in the amygdala can eliminate pain in rats, and genetic testing in people with rare disorders that prevent them from feeling pain have pinpointed several other possible targets for drugs, and perhaps eventually gene therapy. Ever wonder how pain relievers work, or how other animals? Check out these lessons to learn more.
Okay, cool. So that's basically some parts of the how the psychology actually can interfere in what is feeling, what's the pain. So something important. I'm gonna share now. Sorry, 1 second. Share the. Where's it here? Okay. Okay. So basically, what we have here, for example, is the parts of the anatomy of the somatosensory cortex, right? Do you know this part that is called the homunculus? Have you heard about this?
Yes.
Okay, so you know that we have here neurons that actually or control. I mean, in this case, the somatosensory, we have exactly the same distribution for the motor cortex that it will actually manage the movements of our body, but then also we have the neurons that actually sense or process the sensation of these different parts, right? So we have, which is very interesting, different areas of the brain that they will have way more neurons for different parts, which are more sensitive, and then other neurons that they are less sensitive, for example. And that, for example, they communicate with the thalamus, and from the thalamus, they go to the midbrain. Then we will arrive to the cervical cord, and from the cervical cord, we will connect through the root of the spinal cord to the different neurons that neurons in the peripheral system that will actually conduct the sensation that we're getting, right? So in that part, we have different type of nerves that it will actually transfer the information from the exterior to our brain. And this is what I wanted to show you. For example, we have the type of nerve fibers that they carry proprioception, that they are myelinated, and they actually are super fast. So the diameter is quite big, but since they are myelinated, then they will conduct very, very fast information. What is proprioception? Who can tell me that?
Hi, sorry. Isn't it like the way the body like has the perception of its position and its movement, and also it's like it's mainly related to like orientation, right?
It's, I mean, not only orientation, but it's also basically how we sense where do we have our extremities, where are we in the space, and where do we have everything in our body. For example, here we have a very interesting example. Do you know what is the phantom pain? Who can tell me about phantom pain?
It is when sometimes they amputate like a body part and the person still feels pain even after, well, they don't have that part.
Why? I mean, that's it's a good answer, but why? Why do you think that we have this, or this person could have this phantom pain? Who wants to take a leap of faith, and who wants to? What do you think that is happening? So, if I go back to this part here, right? So let's imagine that this person gets amputated the arm. Imagine that then. So of course these neurons, they have these afferent neurons. They have the receptors here, and then they go onto the spinal cord, and then from there go to the brain. Imagine that we cut here the arm. Why a person would feel pain in an extremity that they don't have anymore?
Maybe because the brain still receives like signals from damaged peripheral nerves.
Exactly. That's actually what happens. So what we have is that basically when we cut these nerves, these nerves start to degenerate, but it's not a very fast process. So we have that the other parts of the for example, of the arm that they have the nerves well and everything, when they are actually transmitting to the brain, they can also activate these nerves that they were cut, and that will make the sensation that you are feeling something that you don't have anymore, and that's actually it's a very interesting process, and but it has to be as well with this part between the perception, the psychology, and actually the physiology of the brain. So yeah, that's very interesting. So for example, then we have the touch that is also quite fast. There is a myelinated axon, and then we have that is a bit smaller, and then we have that is actually quite fast as well, between 35 to 90 meters per second. Then we have the mechanical pain and the thermal one that is a bit slower, and the diameter of these axons are smaller as well. And then we have other non-myelinated pain receptors. So as we were saying before, that they are super slow. So as we were saying before, we have other parts or other sensitive transduction that is way faster than the one that we have for the pain. And this is important, right? And nociception refers to the central nervous system and peripheral nervous system processing of noxious stimuli, and these fibers are very small and very slow, basically. Okay, so something that you need to understand here, for example, and it is actually very, very important for you, is that we have injury in any part of our body that will generate different substance that will be activated, like substance P, and then we have ATP, bradykinin, 5-HT, protons, and then histamine and prostaglandin, and these actually will activate receptors, and then these actually will communicate to this neutrophil, and then to the blood vessel, which will activate vasoconstriction and everything, and then it will transduce to the dorsal root of the cell body, here in this case in the spinal cord, and then will communicate to the brain. So this part is the arachidonic acid pathway, which is actually what will activate the COX-1 and COX-2 pathway, and then prostaglandins G2, H2, and these, for example, this arachidonic acid, by these enzymes, will generate these pain messengers that will actually first, for example, it will cause platelet aggregation. The prostaglandin will generate pain and inflammation. And then we have also the arachidonic acid that will generate 5 lipoxygenase pathways, leukotrienes. This will cause bronchoconstriction, asthma attacks, or small muscles contraction. That's basically what I was showing here. Have you ever heard about COX-1 and COX-2 enzymes?
Yes.
Okay. Ana Sofia, what do they do?
Well, they have different functions. They're mainly responsible for the inflammatory effect. So usually, INES are designed to block these pathways.
Okay, That's very good. And basically, what I want you to have in mind is that when we have tissue injury, we have the arachidonic acid that will, by these enzymes, generate the prostaglandins. And the prostaglandins are the ones that are going to give us pain, and they're going to give us the all what we need to understand what is happening in a part of our body, and also to help to restore the homeostasis of that part. Okay, so we will have a homework based on this one, but that will come a bit later. And now we will start with a headache. Okay, so first of all, I will ask someone to read. So I'm going to ask someone to read. One second. My screen. Okay. Who can read this part?
We are not able to see anything, doctor.
Not yet? Wait. Sorry. Okay. Okay, now? Can you see the PDF?
Yes.
Yeah.
Okay. Who can read this part? Should I select someone?
Me.
Okay. Paula, thank you.
Okay. The same, only different. The patient's 32-year-old nurse had suffered from recurrent headaches every few months since childhood. These were generally of a pulsating quality, very intense, and limited to one side of the head, usually at the right side. The pain was most intense behind the eye, accompanied by a strong sensation of pressure. Each attack lasted 6 to 8 hours. During the attacks, she was also very sensitive to light and noise. Whenever possible, she withdrew to a quiet, dark room, avoided all activity, and waited for the pain to go away. Her mother had suffered from similar headaches.
Okay. Second.
She had a severe headache again one Easter Sunday. This surprised her because the last attack had been only 1 week before. This time, the pain came on not gradually but suddenly, out of a clear blue sky, and was much more intense than usual. The pain was all over my head, and she felt as if her head were about to explode. She went to her room and lay down. 5 minutes later, she became nauseated and vomited repeatedly. Over the next half hour, she became progressively confused. Her husband called the emergency medical services. These patients' prior usual headaches were typical migraine headaches, but the Easter Sunday episode was of another kind entirely. A headache of sudden onset and extreme intensity is characteristic of an intracranial hemorrhage. The most common cause is ruptured aneurysm of an artery at the base of the brain, causing arterial blood to enter the subarachnoid space. Subarachnoid hemorrhage (SAH).
Okay, thank you, Paula. Who wants to help her?
I can.
Thank you, Ana.
The emergency physician on the scene examined her and found meningismus, a clinical manifestation of leptomeningeal irritation, generally caused either by extravasated blood or by an inflammatory process. She was somnolent but responsive and cooperative, and had no other neurologic deficits. Suspecting SAH, the emergency physician had her transported immediately to the emergency room of a tertiary care hospital for neurosurgical evaluation. A computed tomography CT scan confirmed that the diagnosis of SAH and revealed a probable rupture aneurysm on the anterior communicating artery as the cause. This was then confirmed by angiography, whereupon the aneurysm was treated with intravascular detachable coils in an interventional neuroradiologic procedure. A headache is a common symptom in everyday clinical practice and has many causes. Primary diseases of the nervous system often cause intense or unbearable pain as a prominent or even sole manifestation. For this reason, neurologists are often consulted to help in the evaluation of patients with pain. The nervous system plays a key role in the transmission and processing of nociceptive impulses and in the perception of pain.
Thank you so much, Ana Sofia. So basically, something that is very confusing in headaches and that I'm gonna tell you now already, it's that actually it's very difficult to know the causes of migraine and the pathophysiology of migraine and headaches. I mean, a part of what we just read now, right? This person had migraines recurrent, and then after all, she had a different kind of headache and a different kind of migraine, if you want to call it like that. And that actually gave the a different diagnosis. But basically, this part of having headaches regularly or having migraine is very difficult to treat. We actually don't know the answer of why are they happening. So it's a bit complicated as a topic to understand. So we're gonna start with to try to define what is a headache, what's the difference between a headache and migraine, and then trying to understand what is a bit of the pathophysiology and how they can be treated, and basically that's basically everything that we need to see for this first week. Do you want to take 5 minutes or we continue? Continue.
Continue.
Perfect. Okay, so I'm gonna share again. Okay. What's it? Okay, so this is the definition that the book is giving us. That a headache is a pain in your head or face that is often described as a pressure that is throbbing, constant, sharp, or dull, and the headaches can differ greatly in regard to pain type, severity, location, and frequency. So this is what I was telling you. Like there is not something that you have like set in stone. Everything can come from different topics or from different sources, sorry, and then they are different and how they are feeling, and it can vary from different reasons. And yeah, I mean, it's something basic. Everyone has had a headache at some point, and yeah, actually is the major reason cited for days missed at work or school, and actually the headaches are the most common for visiting the health providers. So it is, for me, it's a bit complicated to understand that we have so much headache, we can treat them with painkillers, but actually most of the time we don't understand where they're coming from or why they're coming from. So most of the times they come as a result of another pathology ongoing, which is it's important to notice. So first of all, the headaches are divided in different categories. So we have primary headaches, where it's the migraine, the tension type headache, cluster headache, or the other trigeminal autonomic cephalgias. And then we have secondary headaches, and that comes basically for other reason, right? So we have attributed to head or neck trauma, attributed to cranial or cervical vascular disorder, neurovascular intracranial disorder, substance of the physical withdrawal, infection, disorder of homeostasis, facial pain attributed to disorder of cranium, neck, eyes, etc., etc. So that's the part. So we are gonna actually focus. We're gonna leave the secondary headaches because we need to understand that this is coming from other parts of the from other reasons, and then we have the primary headaches that actually are the ones that we are going to try to explain right now. Questions so far? No? Cool. So this is important. Do you have time? Did I promise you that I will share the slides? Yes? Okay. So then, yeah. So this is important, the primary headaches, the definition. That is actually, it's not a consequence and it's not a symptom of other disease. And then here, about 60 to 70 people suffer from headache or facial pain at some point in time in their lives, but only 15% seek medical attention. And the most common from these are the tension type headache and migraine. So we're going to explain for today these two headaches. So here are all of these different the primary and the secondary, but here is how we can actually differentiate them. We have that the site of pain could be diffuse in the whole when we're talking about the tension type headache, or bilateral, and it can last I think between hours to days, and the frequency could be rare to several times per week, and non-unusual phenomena, and it's variable. And this is also actually very important. Tends to improve with physical activity. I'm going to put this one here. So that is actually something that differs from the migraine, that actually it gets worse with physical activity. And this is way less common than migraine, and actually can last also for around 4 hours to 3 days. So we're gonna start also understanding where does it come from, and this is also something that we already talked before. Does our brain hurt? And you already told me before that it doesn't, right? So then one of the explanations that you told me before was that this could come from the meninges or from other parts of the brain. And this is, for me, it's very important. I don't know if you remember from what I told you the first class. I work with something called idiopathic normal pressure hydrocephalus. So the patients that we see here, what they have is that they start building up and producing more CSF, cerebrospinal fluid. So then actually the brain start be pressurized by this increase on the liquid that they have inside of the brain, and then they that start having some changes that actually they lose brain tissue due to that pressure, because it's like it's so much pressure in the brain. But the interesting part is that these patients actually they don't show any pain or headaches. So imagine that part. You start building that, and then what the symptoms that the people they have is like they start having memory problems, they start having difficulties to walk, and they lost control of the bladder, so they start urinating more, like not having this incontinency, having this incontinency. So all of that before having even a headache. And there is another actually very impressive. I think there was also we talked before, but there's this impressive case where a person will start building up this hydrocephalus until he went actually because of a headache. I think it was a headache, and then they found out that this person had lost 90% of the brain. He only had like a very like 10% of brain tissue that was around the brain, and this person could actually perform all their activities, and that is it's a super interesting case of actually how our brain could continue working even from with very little tissue, but also that you can lose so much of the brain tissue, and then you don't have these horrible headaches, and etc. So this comes from the cranial nerves. So actually, who can sense pain comes from these cranial nerves. You can see here all of these. I think you might have seen this in neuroanatomy. When you have neuroanatomy, this is very important. So we have this. I like this because we have the sensory fibers and we have the motor fibers. So we can have pain because all of these. And something very important is the trigeminal sensory pathways that we're going to see in a bit of more detail. So we can sense pain because of these nerves and because of the proximal cerebral vessels. Basically, the carotid. I have another one. No, I'm going to show you in the next one. So basically, because we have this carotid, proximal anterior and middle cerebral arteries that actually can cause the pain, and then we have the dural blood vessels, the large veins, and the dura at the base of the brain. So these cranial nerves and the vascular or the vascularity of the brain is actually what it's going to cause the pain that we feel as a headache. So if you have a tooth pain, is that considered as a headache? So by definition, it comes from the head, and then it's actually activated by the trigeminal nerve. So if you see here, when we have pain in a tooth, it's because the transduction of the pain is coming from these nerves. It can be from the maxillar branch, that if you have pain in the upper teeth, or in the down, how do you say? On the teeth of the teeth of the down, so the down part, that will be for the mandibular branch, for example, and that will cause or be transferred as a pain in the brain. So The trigeminal pain that we could have, they are defined as a cluster headache, paroxysmal hemicrania, hypnic headache, and these are kind of less than common than the other two that we check, for example, and they are kind of more linked to some syndromes and basically, as I was telling you, depending also of a secondary effect. So we're gonna define the different subtypes, like the tension type headache that we're gonna call now TTH. And this is, for example, the most common, as I was saying before. This is around 70% of the cases, 60 to 70%, and sometimes this is referred as a muscle contraction headache, or it can be also caused by stress or psychomyogenic headache. And this is also very important for you to know. We have that there are we have frequent episodic tension type headache, infrequent subtype of episodic headache, and then we have the chronic tension type headache. And this is what I told you before. And this is also what I told you before. One of the main things is that even though we know a lot about headache and we know how to treat it, basically we don't understand very well the pathophysiology of this. And this is one of the difference that I wanted to show you. This is actually affects men and women in the same level, and then we can have it usually in the beginning of the morning. It can last from minutes to days. The intensity is mild, and then we can actually define this as a chronic when you have more than 15 attacks per month, and then episodic when you have less than 15 attacks per month. So that's the difference between the different subtypes of tension type headache, and the pathophysiology is this. The exact mechanism is unknown, but these they have been performing CT scans and fMRI from patients with episodic or with chronic tension type headache, and basically what they have shown is that the people with this headache is basically hypersensitive to in this transduction or nociception from the brain. So if we think about how is the threshold of pain that you have, like you can see and you can compare how is the pain that you would have with the different pain that you could have in different situations. And this is I want to take it from the video that we were watching before. It depends on how sensitive we can become and how sensitive we are to the stimuli that we're having. And here's where the psychology comes in. And then when for example, personally, I don't know if you have had, if any of you have broke a bone. Luna is saying yes. Can you tell us your experience of breaking a bone?
Do I tell like the pain level or
Yeah, what were you doing and then the pain?
I was getting in the shower, um, and then I slipped and I broke my ankle.
Oh, okay. How was the pain?
It was horrible, but it was horrible at first, but then I started like losing sensitivity.
Yeah,
I don't know how to explain it.
yeah. That's what happens. I have broken in my I have broken 4 bones doing different things, and then I can actually rate the pain. And I actually it was 3 bones, and actually the tendons in my knee. And actually, I mean, it is very interesting how or pain can be actually perceived, and that's something that I want to stress out. That is the perception of the pain more than the sensation of it. So you can have it that the interpretation of it when you have these prostaglandins that they are released because of the tissue damage or because of bone, then the brain can actually block that and then say, okay, we are going to cancel that because it can actually generate a shock. And then our brain is actually very smart and it wants to survive, right? So that's basically what we. I mean, for me, it was a bit interesting to read about this pathophysiology that is actually we don't know why, but it's basically based on how hypersensitive sensitive you are to, or the brain is to these parts. But here we have a bit of mechanisms that we could actually kind of could explain what is the headache. So we have myofascial mechanisms that they could like when you increase the tenderness or the hardness or there is inflammation or local ischemia, that can cause peripheral sensitization and then affect into the brain. What is local ischemia? Or what's ischemia? Ischemia.
The death of the tissue due
Nope.
to loss of oxygen.
Okay, loss of oxygen. So when we have loss of, I mean, it's what I mean is it's a right definition, but it's not. It doesn't need to die. You have lost less oxygen, and then the tissue, the cells start suffering, and that sign signals, and then that, for example, could affect and produce headache. Then we have vascular mechanisms, like if you increase the blood flow in the cerebral arteries, or different subtypes of blood flow. And this is more related to this pulsating headache that you can actually experience. And then you have genetic disposition, and then you have that actually not something from the periphery could actually cause the headache, but it's more about the central mechanisms like central sensitization and also actually the difficulties to modulate the brain. Sorry, the pain. So yep, this is actually basically how can we kind of define the pathophysiology of the tension type headache. And then when we go to the treatment, we have so this is the treatment. So you understand what I mean? Like it is very difficult because one of the facts is that it's how you perceive pain, how you perceive the headache, and then you go to the doctor and then tell you, yeah, you have a headache, but then you have to readjust your life, basically. So emotional tension, and then, for example, in the pharmacological part, basically, as we have said, we have acetaminophen, ibuprofen, or combinations, even caffeine. But if you use a lot of these drugs, then you can also have a headache, which is again interesting, and it's a bit of contradictory. And then we go to the psychological part of managing a headache. So important prophylactic measures include relaxation exercise, endurance training, and stress management training. Ideally, a multidisciplinary treatment program. Acupuncture does not lessen the frequency of attack of episodic TTH. Antidepressant can be considered for patients with chronic form of the disorder. So, question here, and this is like there's a lot of people that has not participated. Remember that this participation comes per day. So if you don't participate today, then you will have a point less for the last for the participation evaluation. How do you manage pain? How do you manage your headache when you have headache? That is not pharmacologically. Do you have anything that works?
For me, I go to sleep.
Go to sleep. Okay, that's one. What else?
Maybe drinking water?
Drinking water. Why?
Because as Andy said, maybe it's because we're dehydrated.
Okay. My wife is always telling me when I say that I have a headache, she says, "Did you drink water?" And it's basically okay. Dehydrated. What it does mean? Deshidratación. Sorry. What will be the pathophysiology of it, or the physiology of it in the brain? Sorry, in the head.
Maybe the blood gets like thicker.
The blood gets thicker. Okay, which means
that the pleasure increases.
Okay, so we could have a difference in the hemodynamics of the vasculatory, for example. That could be actually, we could explain that part. Who else? I want a specific answer. Let's see if I can get it. How else you could get pain relief of basically, I mean, of a headache? That is the most common. Let's think about all the pain, but
I've heard that if you put pressure between your thumb and your index finger, it relieves a little of pain. But I've never.
Why would that relieve pain?
I don't know. I think it's some Chinese technique.
It's kind of acupuncture, right? You have
Yeah.
pressure points, and I actually not knowledgeable on that topic, but okay. I mean, could be. And Pamela?
My brother has like very bad migraines, and I've seen him like he says sometimes puking helps. Also, pressure in general in his like head, and like seeing the light hurts. So being in a dark room, and I think I also saw one that they put like pressure on their forehead, like with a water bottle. But yeah, like there's a like different type of things I've seen him do.
Yes. I mean, now we're going with the migraine, and then we will have more of other things that should explain that. But thank you, Pamela. What do you think about eating chocolate while having a headache, for example? Nobody has done that. What would be the effect of chocolate to relieve a bit of the headache?
Maybe an increase of glucose and dopamine.
Okay, that could be one. Glucose. Yeah, and what did you say?
And dopamine, I think. I'm not sure.
I thought
Dopamine.
dopamine. Okay, dopamine. Could be.
Maybe it could release like endorphins, which are like natural opioids that decrease pain.
Exactly. Endorphins. I mean, chocolate is one example, but there is many other substances or food or activities that actually could release endorphins, and that comes with the physical activity that we saw before, right? If you actually increase like you do physical activity, then you will release endorphins, and then endorphins will actually help to relieve the headache. So, and endorphins actually activate dopaminergic sensors and or release of dopamine, and then actually that's how everything comes into place. What Paula was saying before. Cool. Questions so far? All good.
Good.
Okay, cool. Here is the second part of the homework. I want you, it's very important for you that we actually understand how the anti-inflammatories work. So next time, I'm going to ask to a couple of people to tell me who was the Nobel Prize winner, and then other people will tell me I will explain how anti-inflammatories are working. Okay, that's for the next session. Okay, then let's start with the second most common primary headache, that is the migraines. And then the migraines, we have two different, which is migraine with aura and without aura. Okay, and we're going to explain that part. So this is a difference from the tension type. In this case, is basically normally you have it from one part of the brain of the head. That's why it's called hemicranial headaches, and actually lasts for several hours, variable frequency. And this is what I think who was telling me, Paul, I think, or Rebecca, that they are accompanied by nausea, vomiting, photophobia, and phonophobia. Basically, which means that almost all the input from the outside will actually make it worse. And here, actually, the exercise is not working. So this is a total different pathophysiology of actually how it's working with the migraine with the tension type headache. And this is interesting. Basically, they occur. It's more when to young people. Actually, old people almost don't have migraines, and there is more in women than men. So basically, this is the thing. It's more women affected by this, and as you can see here, this is the age. The age variation between the 20s to the 50s, and then the intervals can be, you can have one every month, or you can have like a couple of months, or etc. But then you have it recurrently. For me, I think it was basically what happened. It was I induced that due to the consumption of caffeine that actually triggered the migraine on that time. And after that, actually, it was with aura. I could. It was very weird, and it was something super interesting as a feeling, because I started like actually everything became more bright. Like imagine that you are now there, and then you start to have a light directly to your eyes, and then in your eyes, and then you start like you're not able to see. And that's for example one of the kind of aura that you can get. And then I went to sleep for, I think it was 16 hours, and after that I was okay. I was very tired the day after, but yeah. So, and then I restrict my consumption of coffee, and now I have never had again these migraines, which is quite interesting. So here is a bit more different, right? So here we have so first of all, first thing is unknown as well, how which is actually the mechanism of migraine, which makes it very complicated to treat. But in this case, we have that some studies, PET studies, have revealed that the activation in the brainstem at the beginning of migraine attack and in the hypothalamus in the cluster headache. So if we go back to this part, where it is in the beginning here. So for some reason, migraines start from here, communicate to the thalamus, and then it goes to one part of the brain. Okay, so this is actually how it works, or how it has been defined, the migraine. And this is something important. We have vasoconstriction first, then vasodilatation. So the dilatation of the large arteries at the base of the brain is usually accompanied by unilateral, often throbbing headache. So this feeling of throbbing is what is felt. So first we was thinking that the vasodilatation was once the cause of the headache, but it's still not thought to be the epiphenomena, a result of the same activation of the trigeminovascular system. So this is the part that we need to understand. That is actually what is causing the headache. How it's activated, we don't know yet. But so I wanted to show you this part. So the problem is, this is the vascular system on the brain, right? So if we are thinking that in the base of the brain, and here we have the trigeminal nerves. So, and basically what we're feeling the pain, it comes from here, and then it makes sense that you have first a vasoconstriction and then a vasodilatation, and then that's actually what is causing this type of headache, the migraine. So the changes in the trigeminovascular system are partly caused or accompanied by changing humoral mediators. The neurotransmitter serotonin plays an especially important role, and other kind of vasodilator peptides are also being discovered in trigeminal neurons, including substantia P, neurokinin A, and the calcitonin gene-related peptide. So basically, what is happening is that these substances are released to the bloodstream, and then the trigemin nerves are actually sensing this tree, basically substance P, neurokinin A, and calcitonin gene-related peptide. But this is what is actually causing, or what is think that is actually causing the pain. Antagonists of these peptides and antibodies against them are tested for drugs for prevention and treatment of migraine attacks. So that's basically what we think from here. And this is what I was showing you, right? If we have this, then if we can, these are released to the bloodstream, then it will affect all of these parts of the brain. So then we have the classic one is the migraine without aura, and then we have the migraine with aura. Here, it's in this migraine, it's just having a headache. That's the definition of a migraine without aura. And here we have some of these, how to define how's the difference between a headache and a migraine. So there are, for example, A, B, C, D, and E, and then the patient has to have at least 5 attacks that fulfill the criteria B to D. That's how we're gonna diagnose someone with migraine with aura. The attacks, they have to last between 4 and 72 hours, and that they are basically unsuccessfully treated. They basically, as I was saying before, they have to be only from one part of the head, the throbbing character, and then the intensity has to be moderate or marked, and they need to, or basically it was worse when with physical activity, and also to fulfill this is nausea and vomiting, and oversensitive to light and noise. And also, you have to, we were saying before, this need to be not related to another pathology ongoing in the body. And the chronic migraine is attacks that occur more than 15 days per month in at least 3 consecutive months. And then we have the migraine with aura. So for you that you are lucky now that haven't had a migraine, as me as well. I mean, but this is actually, and I can relate. This is actually how you see when you have aura. So it's very weird. You only see the center. The other parts are blurry, and then the light is quite bright. And here, for example, is the literature says are around 30%. So we have between 25% and 30% of the people with headache problems that they suffer from migraine. And we're going to define with aura suffer from that they suffer from other neurological manifestations before the headache itself begins. So that's the definition. When you have visual sensory disturbances, difficulty speaking, paralysis, vertigo, or abdominal symptoms before you have the headache. So you have something not related to the headache that is appearing before the migraine. And then here is where we have it. So it could be, you can start feeling them few hours to days before the syndrome. So, for example, fatigue, drowsiness, yawning, impaired concentration, photophobia, nausea, anorexia, diarrhea, food cravings, etc. And then you have the aura that is actually between 5 minutes to 1 hour. So when you have aura, you have to actually act very fast, because then you need to find a room where you won't have, and actually be safe. For example, imagine if you are starting having aura when you are driving, so you need to find to stop and to know that you are not going to be able to continue, right? And then you have the headache that is associated to the migraine attack. that it can last from 4 to 72 hours. And then after that, you have the recovery phase, the postdrom, that when you are tired, tired with somnolence, difficult to concentration, and cognitive difficulties. So this is basically the difference between migraine with aura, migraine without aura, and the headache, tension type headache. The pathophysiology is just we're going to talk about the auras that develop between 5 to 20 minutes or 60 minutes before the headache. So this is something that is called as the phenomenon of spreading depression, and this is what we were talking. What is actually in your syllabus? A wave of cortical neuronal discharge followed by neuronal silence that begins in the visual cortex and sweeps outwards. So if you remember, the visual cortex is the last part of our brain, close to the cerebellum, and then that's why it says onwards, right? Because then it starts from there, and then like it can start traveling to the front part. Regional cerebral blood flow decreases during an aura and increases after that. So then we have different subtypes of the aura, as I was saying. The ophthalmic aura, as I showed you before, of the ophthalmoplegic migraine, that is actually pressure in the eye. That's a familiar hemiplegic migraine, basilar migraine, subtypes with aura that could actually feel abdominal pain. It's not uncommon in children, and the cyclic vomiting syndrome, that as we were describing before, that vomiting is actually one of the parts that is very related to migraine. Yeah, and then the treatment, basically, I don't know what happened to my treatment. It disappeared. So basically, in the treatment, it's actually the same as we had in the other so it's actually the same as this one, which was maybe because of that I took it. That is also ibuprofen, acetaminophen, and a combination of all of this. I'm gonna double check, but because I think I wrote it, but I don't know what happened to it. But basically, the treatment, it actually doesn't work very well. So it's difficult for the patients to actually find a solution. Basically, most of the times, as retrieving to a dark place, sleeping, and that would actually is going to be just let the attack to pass. And but still, of course, there are these INES that you can take, and then that will help with that. But for this, I want you to do the homework for the next week, and then we can actually talk about that better on the it's next week. Sorry, for Thursday. Okay, questions. No questions?
No, doctor.
What does throbbing mean? That's basically one of the main difference, or how you can actually detect the migraine. What is throbbing?
Oh, it's like pulsating.
pulsating. Okay, so that's important for you to know, right? Throbbing en español es palpitante. Okay, so that's basically the difference of that you can feel it. You can have headache with throbbing sensation, but it's not the same. Okay. Okay, so yeah, if there's no more questions, then I will. I'm gonna. Here. So I'm gonna check the assistance quickly. We still have a bit of time. Yeah. At 10 minutes after, I have to do the Monday. Today 6. Yes. Okay. Carrera Castillo, Laura Alejandra. No, no está. Ok. Valeria García. Tampoco. Mariana González. Tampoco. Pamela Guzmán. Tampoco. Rebeca Lara.
Ah, Pame sí estaba aquí, solo estaba teniendo problemas con su conexión desde hace rato. Fue la que
Ah,
participó
sí, sí,
hace rato.
correcto. Ok. Rebeca.
Here.
Andrea Lima.
Here.
Paola Fernanda.
Aquí estoy.
Estrella Guadalupe.
Here.
Ana Sofía Mendoza.
Yo.
Ashley Ramírez Delgado. Natalia Rivera Melo.
Aquí.
María Fernanda Salinas.
Here.
María Dominica.
Here.
Fernando Javier Telles. Y Luna.
Here.
Perfect. Thank you. Thank you, guys. Mhm. Okay, perfect. So then we have homework for next session. So let's plan, please, for next week. Next week, sorry, for the next lesson that we could that when we could have it. I don't know how is your calendar. When would you like to have the lesson to recover the one from the Thursday before the Easter vacation? For me, it is okay if we can actually. I mean, it can be. It doesn't need to be at 7 in the morning. It could be at 8. It could be at 9. It could be at 10. The problem now, we are 8 hours different, which is a bit annoying, but I can make it.
Thank you, doctor.
Okay, who wants to give
On what
suggestion?
date are you available?
I almost never available, but I can make time. Maybe Wednesday, no, because I'm the next Wednesday I have a bit of but after that, I mean, it could be Friday 17 or Tuesday 14.
For me, Tuesday works. I don't know if.
Tuesday?
But we have class on Thursday.
No, Tuesday.
Ah,
Martes.
yeah, Tuesday is okay.
At what time?
At 9?
Yeah,
Um,
everyone.
Yeah, that would be great.
or can we vote and let you know like a little bit later when we cannot like agree?
Sorry.
Can we vote on this and we can let you know later so we can all agree?
Yes.
So we can like see each other's schedules and we can like agree with yours.
Okay, let's. Okay, so Valeria, wait, so I put you absent. Right.
I'm here.
Okay. So please check everything for Thursday. So on Thursday we decide, or
Yes.
or the Tuesday. So right now we put Tuesday 14. Tuesday 14 at 9, or it could be Tuesday or Friday 17 at 9 as well, or Tuesday 21st at 9. So just please double check, and then we decide next week. Okay. Okay. Thank you everyone for today. It was way better than last time. Thank you for turning on your cameras. Also, that helped me a lot. And please, if you need anything else, just let me know. And yeah, we start with on Thursday with those with the homework, and then we'll continue with the class. Okay. Questions? Last questions?
No.
Okay. Perfect. Have a nice day. Have a nice week. And see you on Thursday.
Bye. Bye. Take care.
Bye.
Bye.
Thank you.
Thank
Bye,
you,
doctor.
doctor.
Take care.